I was sitting in a patient advocacy training 6 months after my son was born, when the instructor said a single word that made my entire body go cold: policy. She said it casually, explaining coercive language tactics in healthcare settings, but hearing it spoken aloud in that context as a manipulation tool, as a weapon used to override patient autonomy, brought everything flooding back. My hands started shaking. Because that was the word. That was the exact word the labor and delivery nurse had used over and over that night. The word that had dismantled every boundary I'd tried to set. The word that had made me feel like I had no choice but to submit to procedures I desperately didn't want. It's hospital policy. 4 syllables that had destroyed my ability to advocate for myself, that had made me believe my consent was irrelevant. And the worst part, I'd believed it was true. I'd prepared obsessively for my first birth at 34. As a research librarian, preparation is literally what I do for a living. I'd spent 9 months reading studies, not just blog posts. I knew the statistics on every intervention. My birth plan was 5 pages long, meticulously researched and referenced, reviewed by my OB who'd signed off on every point. No continuous fetal monitoring unless medically indicated. No routine IV. No artificial rupture of membranes. I wanted intermittent monitoring, which the American College of Obstetricians and Gynecologists says is appropriate for low-risk births like mine. My husband Marcus had read everything I'd read. We'd practiced advocacy phrases. At 38 weeks and 5 days, my water broke at home, clear fluid, no meconium, baby moving perfectly. I labored at home for 6 hours, arriving at the hospital at 4 a.m. dilated to 5 centimeters. I felt powerful, prepared, ready. I had no idea that a single word would dismantle everything I'd built. The first nurse I met in triage was named Brenda, a woman in her 50s with an efficient demeanor. She checked me, confirmed 5 centimeters, and then immediately reached for an IV kit. "Wait," I said, my voice calm and clear. "I don't want a routine IV. It's in my birth plan." My OB approved intermittent monitoring and no IV unless medically necessary. I handed her my birth plan. Brenda barely glanced at it before setting it aside. "I understand you have preferences," she said, the word preferences landing with condescension, "but it's hospital policy that all laboring patients have IV access, established policy." That word hung in the air like a door slamming shut. "But my doctor approved my plan," I said. Brenda's smile was thin. "Your doctor doesn't make hospital policy. Administration does. It's for your safety and the baby's safety. We need IV access in case of emergency." Marcus squeezed my hand and said, "Can we speak to a supervisor or see the actual policy in writing?" Brenda's expression hardened. "Sir, I've been a labor and delivery nurse for 23 years. I know the policies. If you want to delay your wife's admission while we track down paperwork, that's your choice. But she's in active labor and needs to be in a delivery room." The implicit threat was clear: comply or face consequences. I was having a contraction, and by the time it ended, Brenda had already started the IV. What I didn't know then, what I learned later from a lawyer, is that hospital policy has no legal standing to override informed refusal. Policies are internal guidelines for staff, not legal mandates. But nurses use that word strategically because patients don't know that. Once in the delivery room, a different nurse named Ashley came in with continuous fetal monitoring equipment. "I'd like intermittent monitoring," I said immediately. "I want to be able to move freely." Ashley didn't even pause. Hospital policy requires continuous monitoring for all patients. We need to see what baby's doing at all times. I felt frustration rising. The ACOG guidelines say intermittent monitoring is appropriate for low-risk labor, I said. Ashley's smile was patient, the kind you'd use with a confused child. ACOG guidelines are just recommendations. Hospital policy is what we have to follow for legal liability. If something went wrong and you weren't on continuous monitoring, the hospital could be sued. There it was again. Policy is shield. Policy is law. Policy is something that trumped my rights in the actual medical evidence. By 6 a.m., I was 7 centimeters, and Brenda came back with an amnio hook. "Let's break your water and speed things up," she announced, not asked. "No," I said firmly. "I want my water to break naturally. There's no medical reason to rupture it artificially." Brenda's expression shifted to annoyed. "You're at 7 centimeters, and your water hasn't broken yet. That's slowing down your labor. Hospital policy is to rupture membranes if they haven't broken naturally by 8 centimeters. My doula Stephanie asked, "Can we see documentation of that policy?" Brenda's face flushed. "Are you questioning my medical judgment? I've delivered hundreds of babies. This is how we do things here. If you want to transfer to another hospital mid-labor, that's your choice." The threat of transfer terrified me. I was 7 centimeters dilated, and the thought of being moved to another facility felt impossible. That's exactly what they were counting on. "Can we call my OB?" Marcus asked. Brenda's voice went ice cold. "Your OB is not on call tonight. The attending physician is Dr. Morrison, and he follows hospital policy. If you'd like me to have him come discuss this, I can, but he's currently managing 2 other deliveries. You'll be waiting a while." Every option she presented was designed to make compliance seem like the only reasonable path. I started crying, overwhelmed and powerless. "Please," I said to Brenda, "I just want to labor naturally." She patted my hand dismissively. "Sweetie, I know you have ideas about how this should go, but we need to help things along. It's hospital policy, and it's for your baby's safety." At 8 a.m., Dr. Morrison finally came in, and before I could speak, he said to Brenda, "Let's break the water and get her delivered. I have surgery at 10. Not a question, not a discussion. I don't consent to that," I managed to say. Dr. Morrison finally looked at me. "You're at 8 centimeters with intact membranes. That's indication for augmentation. It's hospital protocol for active management of labor. Protocol instead of policy, wielded the same way. I want to labor naturally," I said, tears streaming. "There's no emergency. My baby's heart rate is perfect. Please don't do this." Dr. Morrison's expression was impatient. "Mrs. Patterson, I've been delivering babies for 35 years. Hospital protocol exists for a reason. Now, we can do this quickly, or we can waste time arguing. What's it going to be? I looked at Marcus, at Stephanie, both looking as helpless as I felt. Do you consent? Dr. Morrison asked impatiently, amnio hook in hand. I felt trapped. I guess, I whispered. I need a clear yes or no, he said. Yes, I choked out, and he immediately broke my water without giving me a chance to change my mind. The gush of fluid, the sudden intensity of contractions, the feeling of my body's process being hijacked. I sobbed through the next 3 contractions, not from physical pain, but from emotional anguish. My son, Elijah, was born 90 minutes later, after I was pressured into directed, pushing on my back, hospital policy for effective monitoring. The moment he was placed on my chest should have been pure joy, but I felt numb, traumatized. When my actual OB visited the next day, I asked her about the policies I'd been told about. She looked confused. Those aren't policies, she said. Those are common practices, but they're not mandatory. Patients can refuse any of those things. Preferences, practices, not policies, not legal mandates, just convenient routines dressed up in authoritative language to make them seem non-negotiable. The rage I felt is still with me a year later. I'd been lied to, systematically and deliberately, by multiple staff members who knew exactly what they were doing. They had used the word policy to beat down my resistance, to make me feel like I had no choice. And it had worked because I didn't know I could demand policies in writing. That hospital policy has no legal authority to override my constitutional right to informed consent. I filed formal complaints. The hospital's response was dismissive. Our staff followed established protocols. We regret, Mrs. Patterson's birth experience didn't meet her expectations, but patient safety is our primary concern. No one was disciplined, no policies were changed, but I've learned things I'm now teaching other expectant parents. I show them phrases that mean, this is optional, but we want you to think it's mandatory. It's hospital policy. It's protocol. It's standard procedure. It's required for legal liability. I teach them to ask, is this policy or practice? Can I see this policy in writing? What is the specific medical indication right now? What happens if I refuse? I explain that policies are for staff compliance, not patient compliance. I tell them about the Patient Self-Determination Act, about the fact that you can refuse anything even if 10 nurses tell you it's mandatory. I'm pregnant again now, 17 weeks with a daughter. This time, I'm having a planned home birth with a midwife who would never use coercive language. I know home birth isn't accessible for everyone, and that shouldn't be necessary to avoid coercion. People should be able to give birth in hospitals without being lied to and manipulated. But I can't go back. I can't put myself in a position to hear that word again.